Failure is not an option.
I've had my ups and my downs.
Phelps with 10 meters left.
3 minutes too good. The crowd roaring. Freeman gets down.
I think it's an absolutely breakthrough experience.
Welcome to the Physical Performance Show, the show designed to inspire the pursuit of your physical best performance. I'm your host, Brad Beer. Listen in as we delve into how the world's top physical performers achieve their success, as well as the highs, the lows, and the journey of getting there. Let's get ready, set, let's go. Listeners, welcome to another episode of the Physical Performance Show. I trust you well, and I hope you've been having a great week and you've been out there pursuing your physical best performance. Hope you've also enjoyed previous guests and episodes of the Physical Performance Show, including last week's guests, Australian marathoner Liam Adams, as he shared around work-life balance, if there's such a thing, and his milestone of running in the Rio Olympic Games. There's a whole lot to be taken from Liam Adams, remarkable Australian athlete, so be sure to jump back over. In particular, if you're an aspiring marathoner looking to run your best marathon, Liam shares his top tips on how to get the best marathon out of yourself. If it's your first time joining us today on the Physical Performance Show, a massive welcome. If it's your 82nd time, then welcome back and thanks for your support. As always, just want to give a quick shout out to a faithful listener who has taken the time to leave a review on iTunes. iTunes reviews help to get this show more audible in more listeners' ears who, just like you, are looking to pursue their physical best performance. So a big thanks this week to Rob Goyen. And Rob has rated the show 5 stars and says, I love Brad's podcasts. I've listened to most of them and I'm working back through the older ones, and so far I've not been disappointed. I haven't really got a favourite because they're all good. However, I really enjoyed the Dr. Peter Malliaras podcast and the recent Bob Larson one. The variety of guests makes for interesting listening, and I can't wait for the next one. Good job, Brad. Morag, thanks very much for leaving a review, and yes, the Dr. Peter Malliaras tendon episode has been super popular amongst listeners, and also the Coach Bob Larson one. So listeners, if you're yet to tune into those episodes, be sure to jump back through the archives and avail yourself of the learnings from both of those great guests, one a tendon specialist and the other an American distance running coaching legend. Talking about legends, today's guest, we are featuring an expert edition, and we've gone live with this, listeners, despite me last week saying today's guest was going to be Ben Morrow. Ben Morrow is now next week, but we've brought this one forward just because I feel that the wealth of information today's guest, Professor Belinda Beck, is going to share around the health of bones of athletes, around bone health in general, is going to help so many people. So we didn't want to sit on this one for another week. We wanted to get this out live. So by way of introduction, Belinda Beck, Professor Belinda Beck, is one of the world's leading authorities on bone health. Professor Beck's published over 70 scientific papers, 120 abstracts, presented over 60 papers at conferences internationally, is on 4 editorial boards for 50 peer-reviewed scientific journals. Belinda's also on the board for the National Health and Medical Research Council. Belinda, or Professor Beck's, contributed to the development of guidelines for osteoporosis position statements and fact sheets for organisations such as Exercise and Sport Science Australia, the US National Osteoporosis Foundation, and the American College of Sports Medicine, ACSM, and of course Osteoporosis Australia. Belinda is both a researcher and also a professor at Griffith University, and outside of that, Belinda is also a key stakeholder in the Bone Clinic found in Brisbane. On today's episode, listeners, we really do a deep dive into the world of bones. Now, we could have spent hours unpacking bones and the significance that they play in our health. However, we were confined to the normal time of a podcast interview, so I did my best to withdraw the key elements in the conversation from Professor Beck around bone health. We cover topics such as bone health across the lifespan, the role that exercise plays in influencing bone health, foods and medications related to the health of our bones, how athletes need to deal with stress injuries, what causes stress injuries of bones. We talk about osteoporosis and osteopenia, the definitions of these, how to measure this. And we talk about the effect of running and other exercises on promoting bone health. So much to take out from this episode. You're going to know someone in your world that's going to benefit from this information, so please share it with them. That's my request from today's episode. But let's jump in with Professor Belinda Beck and let's explore the world of bone health. Professor Belinda Beck, I was one of your students. We were just talking before we started to record a dozen years ago. And Belinda, you did flick a switch in me of interest about bone health. However, a decade on, having been practicing as a physiotherapist for that decade plus, my interest in bone health, Belinda, has been renewed through, I guess, a spate of diagnoses in the work that I do with people that you wouldn't necessarily expect to have osteoporosis being diagnosed in. And as a result, I felt that this was an important topic to cover for the listeners of the podcast. So thanks first and foremost for your time today. And hopefully we can shed some light on this area that's so often not spoken about in healthcare.
Hi, Brad. Yeah, no, it's a pleasure.
Belinda, your story, I mean, as per the bio, your academic record is exemplary. Where did the interest start for you in bone? Just a little bit on you before we throw into the material. How and why?
Well, as it quite often does, I think people's passion in research comes from something personal. And like you, I was a runner. Well, you still are. I'm a mother now, and that's cut my running in half. But I was a runner in school and through uni, and constantly suffered from shin pain. And I was just determined to find out what the heck it was. And the path to find out what it was took me through a master's in sports medicine, where I did an anatomical study of the structures related to the site of the injury. And when I discovered that it was highly unlikely to be muscles and anything pulling on the bone, I figured out it really was a bone condition. And that's how I started trying to figure out what it was about mechanical loading, aka exercise, that caused bone to be painful with certain forms of loading.
And that word's so key, Belinda, the loading of bone. So can you give listeners, so that was in origins of your interest, and really this has been your life's work now, as per your bio, for the better part of 2 decades, correct?
Correct, yeah.
Have you, as you've gone along, realised that there's so much more to know, or is it a matter of like you're running out of things to research?
Yeah, no, you never run out of things to research, because every answer leads to another question. And I think fortuitously I am getting much closer to the answers related to bone overuse injuries in athletic type bone stress injuries. Pretty confident with the answer to that one. Certainly we're getting much closer to the answer to what is the best exercise for bone, and even for people with osteoporosis, and that is absolutely hot off the press, and we can talk about some of that. But now it's just a matter of trying to apply that to all the people who need that information because of all the other comorbidities that occur alongside osteoporosis, which makes it very challenging to actually apply that information that we know. So lots to be done.
So, Belinda, you mentioned there you feel like quite satisfied with the body of work around bony stress injuries. Before you unpack bony stress in the athletic population, can you just put listeners, Belinda, in perspective of a day in the life of a bone? What does a bone have to deal with in a day? What does it have to deal with in a typical year? I think people are often quite surprised that they're not just these rigid structures that sit there and don't do anything. So what's it like being a bone?
Well, I can't tell you what it's like being a bone. I can be a bone head, and that's what I'm often called. So you're right. This is not an inert structure, and obviously I'm biased because I'm really fascinated by the tissue, but it is just a fantastic tissue in our body because it has this ability, as muscle does, to adapt to loads that are put on it, but in a sense, it's even better than muscle because muscle often heals itself with scar tissue, whereas bone will heal itself with pristine new bone. And the way it does that, well, think first as bone being a bank for a lot of minerals, primarily calcium, that are used in other parts of the body. And so if you're not getting enough calcium in your diet, then we go to the bank and we withdraw calcium, and so that we can use it for nerve conduction, muscle contraction, relaxation, all that sort of thing. That's obviously why getting decent calcium in your diet is important. But so bone is this important structure that it holds it up, it protects vital organs, it gives something for muscle to pull on so that we can move, and it adapts to the way that we live. So if you spend your life lying on the couch, your bones don't need to be terribly strong. If you spend your life doing parkour and jumping from great heights, your bones need to be really strong. And so we have a couple of different kinds of cells that are available to resorb bone from where we don't need it, so just like the old Pac-Man machines, and release it into the blood. And then we've got other bone cells that come along and rebuild the bone to where we do need it. And there are times when we are more heavily resorbing bone and we lose bone. That happens naturally as we age. And there are times when we are building bone because we're loading it more, and that happens normally in athletic pursuits.
And that's a nice segue into the athletic world. I think two words that jumped out from that, which you just shared, Belinda, were, to me, adapt. So bone's got that ability to adapt, as you say, to the loads that have been placed on it. And bank, that concept that there's a bank of bone mass. And I guess that this might be a good time to ask and have you, Professor, outline this concept of peak bone mass, because we do hit a peak bone mass and then we do withdraw from that for the rest of our lifespan, if my understanding is correct. And if it's not, Belinda, as my previous university lecturer, I guess I can blame you. But can you outline this concept of peak bone mass and what that means for listeners?
Yeah, this is why being healthy in childhood is so important for everything, but particularly for bone, because we have just about all the bone we're ever going to have on average if you put men and women together by the time we're about 20. And men keep gaining a little bit after that, but women are basically done by the time they're 18. So the bone bank is really built and consolidated throughout throughout childhood and the teenage years, and the more calcium you eat then, and the more really osteogenic bone building exercise you do when you're young, the better your bank. Now after that point, you plateau for a little bit, depending on how active you are, and then you do begin to lose if your physical activity drops off a lot. Now, it's not known whether bone is lost just because of aging or whether bone is lost because we all become less active as we age. And my feeling as a physiologist is that it's the latter. And I think that there is some evidence to suggest that if you stay as active as when you're young, you can hold on to that bone. But because we've never had a study that has been that long, you can't do these lifelong studies because no one will fund them, and it's hard to keep people in studies that long. It's difficult to test that. So instead we use these observational studies where we test people who have been active all their life, and sure enough you do see that their bones are much better than people who've been sedentary. It's difficult though, if you don't have an actual intervention trial, to parse out whether something is genetic or whether it's because of the behaviour that they've done throughout their life. And of course the confound there is the fact that people who are stronger and more robust tend to stay more physically active. So that's why there's always some question about those observational studies.
Yeah, I mean, there's so much here, Belinda. we're going to move towards the athletic population and the stress injuries, but on that peak bone mass, you mentioned that importance of trying to, in those formative years, up to 18 for females, up to 20 years for males, outside of, dietary influences, what other things can, young people be doing? Obviously, activity, being physically active, but are there any other specifics or more specific insights on those things that people can, make sure their kids are doing or not doing to help them hit peak bone mass?
Yeah, for sure. That we know that there's some fairly broad generalizations that we can make and be very confident about, and that is that bone, it likes to be overloaded. If you don't overload it, it's not going to change. So if your daily habits haven't changed in the last 10 years, then your bone probably isn't going to change much either. It's the same when you're growing. So, for example, a swimmer and a cyclist is not going to have the same kind of loading on their bones as someone who's doing heavy weight bearing sort of loading. Now, a lot of people think that running is a great activity for loading bones, but in actual fact, if you were to mechanically test the loads on the bones while you're running, they are actually not that high because the muscles do a wonderful job of protecting them. So the kinds of loads I'm talking about are landings from jumps and hops and also unusual kinds of loading, running backwards and forwards, the sorts of things that would happen on a tennis court or a squash court or during basketball and netball, and all of those kinds of activities are really great for bone. People always gasp when I say swimming and cycling aren't particularly good exercise for bone because they're so fantastic for the cardiovascular system. So I'm not saying that they're bad across the board. I'm just saying if you want to grow bone, they're not the activities that you would go towards. You want to go for more jumping and multi-directional kinds of sports.
I did come across a study, Belinda. I don't think you were part of the contribution to this particular study, but that showed that running doesn't necessarily help build bone mass, but it can help to maintain, at least in the femurs, the bone mass through the lifespan of what's been there, and stop some of the normal rate of degradation. But so they need to be, different loads, unaccustomed things that we're doing, and I guess it's kind of getting out of the patterns and the habits that a lot of us have, and and realising that whilst, as you say, these activities are positive for so many things, it's not necessarily having the effect that many people would attribute in terms of running to bone health, correct?
Yeah, and you're quite right. Long-term running, maintaining that level of loading is great. And I would, certainly running is better than not running, and cycling and swimming would be better than not doing those because they're at least putting muscle loads onto the bones. But I think the actual, I'll give you an example. In the early 90s, there was an observational study of the Stanford athletes, the varsity athletes. These are elite level athletes. They do a lot of training. And what they did is they compared the bones of the gymnasts, and gymnasts have bones like iron, then runners, cyclists, swimmers, to age match and sex match controls. So people of the same age and sex of all those people that they tested, those athletes. And they found if they ranked them on a scale, the gymnasts, of course, had these really hard, great bones. The runners were next, but they were a fair way below the gymnasts. And then equal to the controls were the cyclists, and lower than the controls were the swimmers. Now, that did cause a bit of a stir because we didn't think the swimming was actually bad for your bones. We just didn't think that it was good. And people came to the conclusion that it was two reasons. One, these swimmers were doing about 6 hours of training a day. So that's 6 hours of unloading, so putting in this weight-supported environment. But also these swimmers were probably self-selecting into swimming because they probably had light bones to begin with, which made them somewhat buoyant and helped them be good swimmers. So I never want to discourage people from doing any form of exercise. It is all good, but I just wanted to emphasise that some are much, much better than others for bone.
Yeah, and I think that's an insight that we just intuitively don't get. Unless we're in this health space, and even then, it's not always on people's radar. So, Belinda, thanks for bringing that to our attention. Stress injuries. This is something you mentioned at the top of our time today that you feel like you've got a pretty good handle on from the research front. Can you explain the origin of a stress injury in terms of what's actually happening at the bone level, and then what you've found through your research over the years? I remember as a student, Belinda, you'd had a lot of time spent with military recruits and different things. So what have you learned around stress injuries, Belinda?
Well, the first thing is that we sort of knew the answer many years ago, but we kept thinking, no, there's got to be a better answer, and we kept looking, thinking, it turns out there really isn't. We have to listen to our bodies. And remember, I talked about the fact that we have these two kinds of bone cells. So let's take, for example, a military recruit who has come straight off the couch and gone into their 12-week recruit training at Kapuka. And they're really unfit, their bones are pretty lightweight, and they go straight into a heavy training routine where they're carrying a weapon and a big pack, and they've got unusual shoes on, and they're doing 10-kilometre marches. Well, every time their foot hits the ground, they're putting a big load on it, not just their body weight, but all the other weight that they're carrying. And the bone deforms slightly, so we call that bone strain. So it bends a little bit. Now, that bending signal is actually really important, and that's the signal that tells the bone cells that it needs to adapt. So what happens is all those little resorbing cells come along, and they, I should say quite oftentimes, if there are lots and lots of loads, you can develop little tiny micro cracks, and mostly those are okay, and there's enough bone that can make people continue doing their activity. It doesn't become a problem. But if enough develop, these resorbing cells come along and they resorb all of that damaged material. So there's a temporary window where the bone is actually at a lower mass than it was before. So you've got this perfect storm. You've got a person who had not particularly great bones to begin with. They've started training at a level that they're not used to. The bone has done a lot of bending, formed some cracks. Bone cells come along and resorbed all of those, trying to remodel, trying to do what it's supposed to do, but the formation cells can't form quick enough. So what happens then is that more loading, more cracks, more resorption, and ultimately those little cracks coalesce into stress fractures. And so a big crack happens. It doesn't even have to be that big to be painful, through the cortex of bone, and typically this happens in the tibia or in the fifth metatarsal, sometimes femoral neck, and that happens particularly in women in the military. And then once that happens, the pain of that is enough to make somebody probably stop exercising. And if they don't and can continue exercising at the same intensity, then they do actually run the risk of fracturing right through that stress fracture. And we've all seen those horrible images of athletes who ignore stress fractures, who do have a frank fracture in the middle of a triple jump or something.
And that is the the end stage of accumulative trauma built up, but obviously the pain tends to stop, Belinda, most athletes before they get to that point, but not always. And Belinda, these terms that so many people come across in the athletic population, stress response, stress reaction, what's your best definition of that? And to put it in listeners' layman's terms, what's the best way for us to digest those terms, Belinda?
Well, it is actually quite difficult because the scientific community isn't 100% on one page in terms of the names of these, but I do actually prefer stress reaction or a bone stress injury, because most of them probably are little micro cracks, so small that you can't see them unless you look under a microscope. But that cracking does interrupt the processes of the bone cells and that sets a whole chain reaction of inflammation. And so what you can see on an MRI, for example, is edema, so swelling that happens around those injuries because there is an injury signal there. And of course that edema probably just contributes to the pain of the injury because it'll be stretching the nerve fibers in the periosteum, the covering of the bone. So you won't necessarily see a stress fracture, but you'll quite often see edema. And if you look at the different phases of a stress reaction on an MRI, normally it's on the periosteum, just on the lining of the bone, and then it can go on the inside of the cortex of the bone, so in the internal cavity, the medullary cavity of the bone, you'll see edema there as well. And finally, you might see a signal in the actual cortex of the bone where there might be an actual stress fracture. It's quite difficult to see stress fractures. Very rare to see them until they've actually started healing, actually. But that edema is an absolute telltale sign that something's going on.
And is that edema, Belinda, analogous to a term that I've certainly come across clinically, and that's an insufficiency fracture? Is that a term that scientifically you guys deal with, or is it more radiological term?
Well, so by definition, I think an insufficiency fracture is really just a fracture that has occurred because the tissue is insufficient to withstand the load. So sometimes, yes, you can call a stress reaction that. I tend to stick with the term of stress reaction just because that is more of the athletic sort of injury, just to separate it from an insufficiency fracture that could happen in osteoporosis in old age when somebody's, say, the trabeculae in their vertebrae, the spongy bone inside their vertebrae, is just insufficient to withstand the load of, say, carrying the shopping, which is, a different injury again.
Yeah, no, that's great. Belinda, there's been lots of listeners to the show that have popped up questions, and for the purpose of maintaining confidentiality and not having this become an advice session from Professor Beck without knowing everyone's unique circumstances, if I just share a few headlines around this world of bony stress injury in athletes, if I may. Someone's asked, why do stress fractures sometimes not heal? In this case, this particular athlete, Belinda, has reported on and off episodes of stress injuries to their shin. So anything from your world that you'd add to that situation, Belinda?
Yeah. The dreaded black line is a classic tibial stress fracture that happens on the anterior or the front cortex of the tibia. There's a couple of reasons why that may not heal. Number one is the nature of why the injury happened in the first place. If you think back to when I taught you anatomy, imagine the shape of the tibia, and it's got a little bit of a bow in it, and that bows forward. So every time you load it, it bends so that it bows forward. That means that if you get a crack in that front cortex, you're actually pulling the edges of the crack apart. So the nature of that does tend to prevent healing a little bit. There are some people who think blood supply there is not that great. I'm not sure if I totally buy that, but it's normally an injury that's happened on that cortex of the bone. The athlete hasn't stopped quickly enough to prevent more loading, and then a gap occurs between the edges of the crack, and then it's hard for the bone to sort of reach each other and heal. They do call that a dreaded black line because you can see it in radiological imaging as an opaque line. There's no bone there. It's not good if you've got that, and people do tend to need grafting or some kind of stimulation to make it heal.
And Belinda, I kid you not, I still use my forearm to try and demonstrate that for patients. Hence, as from your learning, so that has never left me. So thank you for that. It doesn't. Oh, sorry, a decade plus ago. You mentioned bone grafting. I mean, someone's written in here and actually said that they had a tibial stress fracture. It didn't heal despite 8 weeks in a moon boot, 3 months in an air cast, and 8 days post tibial curette and bone graft. And so there you go. That's sort of exactly what you've just described, Belinda. Shifting gears away from some of these stress responses to bone and injuries and pathologies in stress fractures, Words and terms like osteopenia, osteoporosis. Can you speak for a moment around pathologies of bone and what they mean, the definitions of them, if that's possible?
Sure. The definition of osteoporosis is actually more complicated than is convenient, clinically speaking, because really osteoporosis is a condition that predisposes people to increased risk of fracture. Now, there can be numerous things that predispose you to an increased risk of fracture. It might be that you just fall more, but the way the World Health Organization chose to define it, probably back in 2000, was using a T-score, and this is based on a scan that you have on a bone densitometry machine, and it gives you a measure of your bone mineral density because it's an X-ray machine, so it measures the mineral in bone. So your bone mineral density gives you an estimate of how much bone you have, and we do specific scans of the spine typically, and of the hip, and sometimes of the wrist. So the WHO decided to say that to be diagnosed with osteoporosis, you would have to have bone mineral density, or BMD, that was 2.5 standard deviations below the average of somebody your sex, so if you're a man or a woman, aged 20. So regardless of your age when you were scanned, your score is compared to somebody your sex aged 20. Your sex and race. So, for example, with you, it would be a white male aged 20. And so your BMD score is plotted on this big plot of reference data, and wherever you fall in relation to that value allows us to decide whether you have osteoporosis. Now, osteopenia is really just on the scale of BMD. You don't have to be minus 2.5. You have to be between -1 and -2.5. So osteopenia is really just low bone mass, and osteoporosis is very low bone mass, determined by bone mineral density on a bone densitometer. And I should say that if you have osteoporosis on that definition with that T-score, the T-score is what they call the standard deviation, you are at greatly increased risk of fracturing. However, because if you plotted everybody's BMD onto a big scatter plot, you get one of those classic bell curves, you have most people in the middle and a few people out at either end. Well, the ones out at the minus 2.5 end are the ones who are very low. And osteopenia, you'll see that comes more to the fat part of the bell. And that means there are many, many more people with osteopenia than osteoporosis. And because of that, most people who suffer an osteoporotic fracture are actually classified as osteopenic. They're not minus 2.5. So even if you are not minus 2.5 on your T-score, your BMD T-score, you still could be at risk of fracture.
Yeah, so the definition is really increased risk of fracture. And then, as you say, it's sliding, there's so much there. You mentioned T-scores. Z-scores come back on people's reports. What degree of importance do you put on the Z-score, and what is the Z-score, Belinda?
So remember how I was saying your BMD is compared to what they call the young normal, the 20-year-old? Your Z-score is compared to somebody your own age. So it's still a standard deviation, but it's just comparing just to a person your age. So in terms of your diagnosis of osteoporosis or osteopenia, we use the T-score. But if you want to get a sense of, well, yes, I'm low compared to a 20-year-old, but how do I look compared to my peers? You may still be above normal for your peers, but the thing is that the WHO decided that it didn't matter where you were related to your peers, because the risk of fracture is the same whether you're minus 2.5 age 20 or 50 or 90. The risk of fracture is greatly increased.
Yeah, hence the definition. And imaging, Belinda, if people do want to get checked out, I mean, bone mineral density scans are the way to go. Is there any other way that people can get meaningful insights into their bone health?
You can, scientifically speaking and theoretically, yes, you can find out bone mass in other ways, but there really isn't a standard way to do that in any easily understandable way. Your GP probably won't be able to interpret any other form of imaging than a BMD scan. I've read quite a few scientific papers with people having scans for other things, having a CT scan, and the scientists have looked at the bone mass and said, oh, we can tell they've got osteoporosis from this. But if you gave a CT scan to a clinician, they probably would not want to diagnose from it.
Listeners, a quick break from Professor Belinda Beck's sharings and learnings. I hope you've had a pen and paper. Today's episode, as always, is lovingly brought to you by POGO Physio. We exist to help you perform at your physical best, and we do this through our industry-first, fixed price and unlimited access 2, 6 and 12-week finish line physiotherapy programs. It's real simple. We want everyone who walks through the doors of POGO Physio to get a high-five moment where they hear from us at congratulations, you've crossed your physio finish line and you're fully rehabilitated back to your physical best. It's about getting the treatment that you truly will benefit from, as opposed to the treatment that you can afford on a session-to-session traditional physiotherapy model. Finish line program patients of ours benefit from state-of-the-art exercise equipment and the unlimited nature of the programs. For more information about the Finish Line programs, jump over to pogophysio.com.au, and if you're interstate outside of the Gold Coast or Queensland, be sure to check out POGO Partners as it brings the Finish Line programs to you in 2018 and beyond. But let's jump back now to Professor Belinda Beck around bone health. Belinda, those words, osteoporosis, osteopenia, two listeners have written in, and one's a 31-year-old male triathlete recently diagnosed with a sacral stress fracture and then subsequent osteoporosis diagnosis. He's just started Prolia injections, and we'll get to medications and things. The other listener, Belinda, has written in and said she was diagnosed with osteoporosis when she was 26, secondary to premature ovarian failure, and her bone score, she's now 34, haven't improved a lot. It brings me to this point of people, I guess, assume that osteoporosis is just a disease or a condition of maturity, but that's not necessarily the case, is it? How is it possible that people of younger years can be diagnosed with osteoporosis? What are potentially some of the things that may drive that process?
Good question. There are a number of things, and as you say, osteoporosis is really closely related to age, and definitely age is the biggest risk factor. Older you are, more likely you are to have it. One of the worst things for bone is corticosteroids. And so some people who have chronic inflammatory conditions, perhaps they have quite severe asthma. Some people have conditions where they have to go on 6-month courses of corticosteroids. That does terrible things to your bones. And the younger you start that, the worse it is, because your exposure will be longer. So steroids is a classic. Some of the more dramatic illnesses, cancer and so on, have the chemotherapy associated with them, does terrible things to bone cells. So yes, you see people with treatment for breast and prostate cancer with bones that have really suffered as a result. And as I say, many of the inflammatory conditions where corticosteroids is the primary treatment do suffer.
Yeah, right. And genetically, anything that can feed into it genetically, Belinda?
Sure, I probably should have said that first because I think we'd have to say that genes really control by far the largest degree of risk of getting osteoporosis. In fact, they think between 70 and 80% of our risk of osteoporosis is really inherited. So you just have to look at your parents and your grandparents and see if they're stooped over with the dowager's hump, or even if they're not, if they've had a fracture, a low trauma fracture, the chances are their bone mass is low, and the chances are yours will be too. So that gives you extra incentive to work as hard as you can to maximise peak bone mass and lose as little as you can throughout your life.
Yeah, great. And I'm coming back to that phrase, work as hard as you can. Belinda, what's the influence or the effects of hormones? I mean, is there a direct link to, where I'm going with this is in the endurance sporting community. I know often there's hormonal deficits in, testosterone, sex hormone for males, and, is there any link between levels of hormones and bone health?
Oh, definitely. Estrogen is probably the most powerful of the bone hormones, and that is not just for women, that's also for men. Even though men's levels of estrogen are very much lower, it still is a really powerful hormone. It's one of the reasons why women suffer from osteoporosis more dramatically as they go through menopause, because the withdrawal of estrogen has an effect of taking the brake off those bone resorbing cells I was telling you about. Those are called osteoclasts. If estrogen is withdrawn, as it does, and it plummets at menopause, then the osteoclasts say, yippee, it's time to eat bone, and they just chomp through the skeleton for up to sort of 5 to 8 years, and a dramatic loss is seen at that time. Men don't have the same dramatic sort of withdrawal of estrogen, but certainly testosterone also is important for bone, and the gradual withdrawal of testosterone has a similar effect, maybe not as dramatic as estrogen though. Now, talking about the female athlete, this is a reasonably complex area, but likely due to the classic body's reaction to its environment. We used to think, in the old days, they used to think that a certain amount of body fat was required to maintain estrogen levels in the blood and maintain menstruation and bone health. Well, it turns out it probably doesn't really have to do specifically with levels of fat. It has more to do with energy balance. So if somebody is chronically in energy deficit because of overtraining, then the body thinks that it's in a drought. And in that situation, the effective thing to keep populations down is to drop estrogen so that women won't ovulate, get pregnant, and have a baby in a drought. So that drop, and I'm sort of expanding this metaphor a little, but the idea is this starvation situation drops estrogen in the body in young women who are overtraining, and that will have exactly the same effect on bone as going through menopause, because the brakes will be taken off the osteoclasts and they will resorb more. So it really is absolutely vital that young premenopausal women do not become chronically in energy deficit when they're training, because their bones will suffer.
Wow, Belinda, that's so powerful. I mean, this show has featured the stories of many athletes to date, and many of those are female runners who have shared openly around their bone health dilemmas through their athletic career. And so it really is about energy balance, as you say, not so much body fat percentage. So is another way of thinking about energy balance kind of, nourishment, making sure the food intake's correct and the energy expenditure is not, excessive, which I guess is hard in say, the world of endurance athletes, where, say, runners, take an endurance runner. It's a tricky maze to navigate premenopausally.
Well, I mean, you can expend as much energy as your body will allow, but you just have to make sure you're taking an equal amount in. That means if you're going to do those endurance and hyper endurance activities, you need to eat a lot. And you need to eat a lot of good food, and you certainly need to make sure that you're eating enough calcium. And one of the problems that endurance cyclists have suffered, I've talked about the fact that cycling's not a weight-bearing impact sport, so it's not really that beneficial for bone. But they also sweat a lot, and when you sweat, you lose calcium in that sweat. So there have been some studies done in the US where they have tried to supplement cyclists with extra calcium to try and prevent the bone loss that occurs over the course of a cycling season.
Wow, that's fascinating. So if you're a high salt excreter, you could be a bit more at heightened risk of poor bone health.
Maybe.
Potentially as an endurance, I'm extrapolating here, and I'm sure your scientific brain's going, no, don't take it that far. I'm speaking from a fascinated clinician here, Belinda. Belinda, you mentioned the term good foods. Can you give us a little bit of an insight into what that means to you in your world? What would good foods look like for people trying to maintain and optimise bone health?
Well, and with the caveat that I'm not a nutritionist or a dietitian,
of course,
and my experience is really confined largely to calcium, vitamin D. I from what I do know, just as a physiologist, the old-fashioned food pyramid is still pretty valid. I know there's a lot said about low-carb diets these days for people who want to lose weight, and we've seen that cutting carbs down can cause dramatic weight loss. But for somebody training, that can be really diabolical. You need the energy to provide the muscles when you're training, and the other tissues. But the key is balance. Obviously, fruit and veg are vital because that's got the vitamins and the minerals in that are used for all these sort of micro-physiological processes. And when it comes to calcium, it gets a little tricky if people don't like dairy or can't tolerate dairy, because dairy is by far the most important, most bioavailable, most readily absorbed source of calcium, and it's also the most calcium rich. So people often say, well, I don't like drinking dairy, I want to get all my calcium from green leafy vegetables, there's tons of calcium there. Well, that's true, but it's not really bioavailable, and there are things called oxalates in spinach and rhubarb that actually prevent the absorption of calcium, so you're not getting the calcium out of those vegetables. Whereas the calcium in things like milk and cheese and yogurt, but also salmon bones. If you eat tinned salmon, make sure you eat the bones. That also is highly bioavailable. So calcium really important. Doesn't matter how much calcium you're getting though if you don't have adequate vitamin D, because vitamin D assists the absorption of calcium. So we live in a society where we're very averse to too much sun exposure, which is a good thing because we do need to protect our largely Caucasian skin from our very strong Aussie sun, but we've kind of gone a little extreme to the extent we tend to cover up at all hours of the day, and in fact early in the morning and late in the afternoon when it probably is wise to get some sun on the skin to make sure that you are converting that into vitamin D and getting enough to absorb your calcium. The Australian New Zealand Bone Mineral Society and the Australian Cancer Council did come together to form some guidelines as to safe exposure to the sun, knowing that there was a little bit of an epidemic of low vitamin D. Even in Queensland, a study showed that about 38% of people are vitamin D low at the end of winter. So, and in places like Hobart, in the middle of winter, you need about an hour of sun to get the vitamin D levels up. So, in the middle of the day. So, vitamin D is a really important element of your diet if you're not getting enough sun.
And if you're not getting that sun exposure, supplementation, Belinda, for calcium and vitamin D, is there a body of support literature-wise for supplementation?
This is an area where there are actually two schools of thought. Quite a lot of controversy because a recent, probably 2010 now, I think the first meta-analysis came out showing that for supplements, just calcium, not with vitamin D, supplements over 1,000 milligrams a day, I think, was associated with a 30% increased risk of heart attack. And this caused a massive flurry, and people like crazy went off the calcium supplements. I think there's been a lot of toing and froing ever since. There is very little evidence to show that, say, 500 milligrams supplement of calcium a day is associated with increased risk. Certainly if you have some vitamin D in that supplement as well. I personally, with the way I manage it in my family, is that I just make sure that those two elements are available either with sun exposure for D and through the diet, because they are by far the best way to get calcium.
Yeah, no, great advice, Belinda. And there's so much to cover and always so little time. Moving off food, medications, just briefly. Prolia injections, often used for osteoporosis, and I know it'd be the same caveat in terms of what you can, not giving blanket advice here to everyone, but the role of medications from a research point of view. Anything you'd add on medications for people that are diagnosed with osteoporosis, Belinda?
Yeah, okay. Certainly a caveat that I'm not a clinician. I'm not a GP or an endocrinologist, and they're typically the folks who do prescribe those medications. I am pretty familiar with the drugs that are available, though, and certainly the bisphosphonates. These are drugs that act on the osteoclasts, the bone-resorbing cells, have been used for many years, and they're considered to be relatively safe and effective at growing bone mass. Prolia is a newish kid on the block. It's molecular name denosumab. It's the injection. The last I spoke to an endocrinologist, I thought that they were not necessarily recommending Prolia for younger people. They were still suggesting that perhaps a bisphosphonate was better than Prolia when you're younger. But that's certainly something you would need to talk to your doctor about. The answer to the question is, if somebody was a young, healthy athlete, I would definitely have a good consult with a doctor who is aware of their form of training, look at all the reasons why they might have osteoporosis and try and address those first, and potentially have the medication as a fallback. When it comes down to older people who are diagnosed with osteoporosis, and we're talking sort of postmenopausal women and older men, then it's probably a more straightforward age-related osteoporotic diagnosis, and so the prescription of those kinds of medications is a little more straightforward. There are some side effects associated with the drugs, but most of the doctors think that they are minimal. I personally think I speak to a lot of clients who have been on the medications and they really don't like the gastrointestinal side effects or some flu-like symptoms occasionally, and they prefer to just not be on medications if they possibly can help it. I do know that they will grow bone mass in most people. They don't always prevent fractures, though, because they won't prevent falls, and it's one of the reasons why I feel so strongly about exercise as being a really important therapy for osteoporosis, because not only can it grow bone, but it can also improve balance and prevent falls. So it's sort of the double whammy.
You mentioned that it can grow bone, and I think the myth is that bone cannot be grown or improved, but you live and breathe this, Belinda, and I think this is potentially a key takeaway that if you're out there, you can improve your bone mass, correct?
You can. Now, again, all kinds of caveats because everybody is different. I was saying that most people respond to the medications. The ones who don't, we talk about non-responders. And so there are some people who don't respond to medications. There are also some people, not a huge number, who don't respond to exercise. The ones who respond the most are the ones who need it most, fortuitously. So people with very low bone mass, the ones who will, their bones will hear the signal, that mechanical signal, more than, say, a big, I'm trying to think of somebody that everybody would know, that, a very large rugby league player, for example, probably has bones like iron. And if he did more exercise, it's highly unlikely that exercise is going to have any effect on his bones because his bones are already as strong as they need to be. But if you think of the very slim 80-year-old lady who lives next door who's never done very much exercise and has just had a diagnosis of osteoporosis, that person will really benefit from exercise.
Yeah, fantastic. So, Belinda, exercise, you spend your world in the research, but you also have the bone clinic there in Brisbane. So where can listeners that want to find out more about the research, but also the practical applications of that research knowledge that you've accrued, who want help for their bone health, where can they find you, Belinda, in the bone clinic?
Well, as you say, we have just opened the bone clinic a couple of years ago specifically for people with osteoporosis because there wasn't anywhere for them to go to get safe exercise, because as I've been discussing, the important thing for bone is to load bone with high intensity, and you can't do that safely unless you're supervised. So the bone clinic is in Coorparoo in Brisbane, and we have a program we call Onero, which is a heavy lifting and impact program that we introduce very gradually, even for people who are very frail, and we build them up to a point where they can actually do this exercise program. We have exercise physiologists who run the program. We've licensed the program to exercise physiologists and physios so they can do the Onero program around the country. And to find us, the best place to go is probably www.theboneclinic, all one word, .com.au, and all the information is on there. There's a phone number there where you can call our lovely receptionist Donna. She'll give you all the information you need.
Fantastic. Belinda, if you could boil down, and listeners, I encourage you to jump over the show notes and we'll tag all that up for the Bone Clinic. And I've been spending time in there as a clinician on the site looking at some great content and resources. So, Belinda, thank you for that. If you could boil all your learnings, this is almost an impossible question, into one piece of advice that you'd like listeners to take away, what would it be, Professor Belinda Beck? Your one piece of advice to optimise bone health through the lifespan?
My one piece of advice, I would have to say always load your bones, and you're never too old to begin.
Wow, beautiful. Belinda, we like to have every guest of the show issue a physical challenge for the week, something to inspire activity and encourage people to be active. What's Professor Belinda Beck's physical challenge to listeners for the week going to be?
Take the stairs. And when you take the stairs and you come back down them, jump down the stairs using 2 feet and land firmly on your feet when you land. Now, if you're a bit shaky, hold on to the railing while you do it, but take the stairs, get some impact.
So just to be clear, so if you're going down the steps, take the stairs, and you obviously go up the steps, but if you're going down, jump off the last step and land on 2 feet.
Well, I would jump off I would jump down the whole way. If you don't want to look like a complete goose, you might want to do it just off the bottom step. But if you're in the comfort of your own home and you've got a hand railing to hold on to, jump down the stairs, land 2-footed, And depending on how sore your knees and hips are, you might have to bend your knees a bit. But the stiffer your legs are, the more jolt your bones will get, and that's good for them.
Oh, Belinda, you know how I'm going to be ambulating downstairs now, no matter where I'm at. So, Belinda Beck, Professor Belinda Beck, it's a standing ovation from me. I've been one of your beneficiaries of your knowledge over the years, so thank you for everything you've taught me. Thank you for everything you've imparted to the listeners today, and we wish you all the best. And listeners, do jump over and avail yourself of all the great resource over at theboneclinic.com.au. Thanks, Belinda.
My pleasure, Brad.
So, listeners, there you have it. Another episode of the Physical Performance Show. I trust you enjoyed today's episode, and I know, I don't need to trust, that you took some great learnings from the wisdom and the clinical expertise that Professor Belinda Beck so generously shared with us. On that, don't let the information go to waste. If there's something in there that Belinda Beck shared today around the health of your bones, be sure to take action yourself. If you need to avail yourself of the excellent resources on the Bone Clinic's website, we'll tag that up, listeners, in the show notes. Likewise, search for Belinda Beck online, and if you've got questions, seek out the expertise through their clinic. They are truly the leaders in this space. And likewise, if you know someone that will benefit, please share it with them. This is so important for people's health. Listeners, if you'd like to subscribe to the podcast, it's very simple. Simply hit subscribe from within your favourite podcast app, be that iTunes or SoundCloud or whatever it may be. And each and every week as we go live with the Physical Performance Show, it'll be populated inside your device. A massive thank you, as always, to the two very good folk who make this show possible, Mr. Daryl Misson, our audio engineer extraordinaire, and also Sophie Walker and all things marketing at POGO and also marketing and administration around the podcast. Lastly, if you're into running, you can now pick up a copy of my Amazon running and jogging bestseller, You Can Run Pain Free, over on Audible or iBooks. You Can Run Pain Free, the 330-page 5-step framework, is also available in the good old-fashioned print version over on Amazon, shipping internationally, or pogophysio.com.au, shipping inside Australia. It's also available, of course, in digital or Kindle versions. Listeners, coming up on next week's episode of the Physical Performance Show, I catch up with great British marathoner, Commonwealth Games marathoner, Ben Morrow. Ben's also been the winner of the City to Surf, and a great guy with some great tales to tell around all things pursuing your best in a pair of running shoes. So be sure to tune in next week to the Physical Performance Show. Have a great week. Until next time, keep pursuing your physical best performance. I'm Brad Beer, and this has been the Physical Performance Show.